How are you?
Not too bad, not too bad. I looking forward to today, so it should be good. Should be good. We're gonna wait for. Oh, there's Laura. How's it going, Laura?
Perfect.
How are you?
Good. How are you?
Oh, not too bad. Trying to reopen a clinic. That's about it.
That's exciting.
Yeah, because you guys are. What did BC? Aren't they announcing it today?
I think so. Yeah, that's what I've heard.
Okay, that's good. Yeah, it's a bit nutty trying to get things going, but I think it's okay.
Yeah, I'm thinking mid-May is what BC is gonna end up deciding, but don't know for sure. So.
Yeah. Yeah, I think so. I heard another clinic already announced they're opening in BC on the 19th. So I'm like, unless they have some insider info, I don't know what's going on there.
They're just being very hopeful, maybe.
Yeah, I don't know. They must have some intel, because even like when I kind of knew before, like a couple of days before, what was going to likely happen. But even then, there's no telling what the date's going to be decided or what's going to happen. So, yeah. How was your day? The weather's pretty good there, I see from the back light.
Yeah, it's sunny. It's gonna
Yeah.
be warm. It's perfect.
That's nice. I think it's going to be 18 here today.
Oh, that's pretty good.
We're across the street from a golf course, and like, fortunately, the golfers are back because it's really good entertainment for me.
Yeah.
I saw one guy just lose it at one of the holes, like he was golfing alone, and this was last summer, and like he kept putting and clearly kept missing, and he was just so angry, and it was just, I watched the whole thing unfold.
Yeah. I usually just pick up my ball and throw it and hope for the best.
Yeah, I usually just stay home and not play golf. I'm too competitive, so for me, I can't play. I just can't. People are like, oh, just have a couple beers, and I'm like, well, no, I need to win.
Yeah, it's a frustrating sport. It can be frustrating.
I need to win. No, this is good. Thank you for coming on. I appreciate it.
Yeah, I'm excited. This will be good.
Yeah. Is there a way you could go into like the landscape or the potentially?
Will that work?
Yes. That works. No worries if it doesn't. I can always change mine.
Let me just prop it up on something.
Okay. I can change mine if needed.
Oh yeah, we can do the same. This is perfect. I have a bunch of books.
Oh, nice. You got all set up. Mine's like permanently set up here, so I don't have, I just have to put the phone in the tripod and that's it.
Yeah.
Okay, perfect. If that's okay with you, if not, I can turn mine.
No, yeah, this is perfect. This works.
Okay, perfect. This is good. Thank you again for doing this.
Yeah, no problem.
I appreciate it. It's fun to do. It's like, I was hoping that I'd get like a multi-million-dollar contract for like some sort of physio TV show where we just interview other physios, but that hasn't happened yet. So
it could still happen though. You never know.
Here's to dreaming. And then like I'd still practice. I wouldn't, just take my millions and have fun with it. I would make this place even better. So yeah. So it's great. It's kind of cool because like there's physios from Ontario, like Toronto that I've attended, a couple from BC, yourself, which is awesome. You get lots of like Judy's going to be on tomorrow, so all my mentors have added some to this. So I think it's great. So we'll start off with you, Laura, about who you are, what you do, like your clinical interests, like whatever it might be. I know some of them, but I think a lot of people here might not. And then kind of just explain what we're going to do today. And I got the PowerPoint open. I got the Return to Running program open if we need to, and one of the articles that you sent me today. So.
Okay. Yeah. So.
I'll let you take it.
Yeah. So I graduated. Did my schooling through U of A, but the Calgary campus. So there's only 18 to 19 of us there. I graduated December 2018 and then took a job at a private clinic in Edmonton. And then from there, I accepted a sport physio fellowship done through UBC through Alan McGavin Sports Medicine. So yeah, since August, it was primarily working with football, basketball, a little bit of baseball and hockey. So kind of gave me just some experience with a ton of different sport teams, which was really awesome. I did some research there, got to be part of rounds at UBC. So that was all really great. So I've kind of geared a little bit more towards sport physiotherapy and might challenge the sport physiotherapy certification. So that's my goal, hopefully in September, depending on how things go. But yeah, so my friend, so Michaela Jurgens, who was in the Calgary cohort with me, and I started this 5-minute physio just to do like some brief videos and kind of education for anyone who's interested. So it's been really awesome and keeping us somewhat busy. So that's why we started that, and thought this was a good opportunity to just kind of keep busy and then also promote our 5-minute physio, which has been fun.
Yeah, it's cool. So everyone follow them and check it out. I look at all the videos, and it's definitely, it's good. I'm kind of envious because it's efficient, and it's just like you get all the info in a few minutes, and so I like it a lot. It's clean too. It's streamlined.
Yeah. It's been good.
That's awesome. And you and I met in Edmonton here, so that's kind of, I know we didn't like work together too much, but I just kind of came into the clinic and made crazy comments, and that's how you may have known me.
Yeah, you'd work out in there. That's, I think, when I saw you the most.
Oh yeah, that's true. It was a nice facility, so yeah.
Yeah.
Now I work out here, so it's all good.
Yeah, it's still super nice.
Yeah, for sure. No, it's good. Thank you again, and I'm actually looking forward to it. I know doing the slides and stuff, I'm like, this is going to be very important for people to listen to and try some things out.
Yeah.
It's a very common issue.
Yeah, definitely.
Yeah, and I'll just I'll line it up. You can continue chatting about the topic, and I'm just going to line it up to the computer so that way everyone can see.
Yeah, sounds good. Yeah, I dealt with a lot of hamstring strains, especially with like football and then some track and field as well. So yeah, it was quite common, and one that was like a very serious injury to rehab properly, just because the rate of re-injury is so high. Really important to get the strengthening, make sure that the athletes are ready to return, or anyone who gets a hamstring injury, because you don't want to keep re-injuring it. It's one of the highest predictors of hamstring injuries, a previous injury itself.
I inserted this picture here just to
Perfect.
If someone doesn't know what a hamstring looks like, here's an image of it. Sorry, I'll let you go, Laura. There we go. Meet the
Do you want me to talk? I can talk through the slides. Do you want to talk through the slides? It's up to you.
Oh no, you can talk through the slides that way, because it's your material. I want you to definitely talk through.
Okay. You're just really throwing it all at me.
No. It's fine.
No, that's okay. Yeah, so for those who don't know, the hamstrings are made up of 3 muscles. So it's the semitendinosus, semimembranosus, and then biceps femoris, which is the big one. I've seen more commonly biceps femoris injuries. But yeah, it's all on the back of your leg. So it kind of comes up and inserts kind of past your leg and then up into your ischial tuberosity. So kind of that sit bone on the back of your leg. So it does hip extension and knee flexion, and then depending on the group, so it can do some rotation through the lower leg as well. So there's some component of external, internal rotation.
And I just put like a referral pattern. So for people that have had pain in that area, here's some common areas where you can feel pain. Lots kind of in the glutes and the butt area, and then back of the knee, and in between. So it can radiate in quite a few different areas. So this is just to show everyone that the area of pain can be quite large. Focal points are up in the glutes and kind of in the back of that knee. So I'm sure a lot of people have had this issue. I've had this issue. I still have this issue sometimes, but yeah, so I get it kind of more closer to the buttocks. So yeah, so that's the chords. And then for the slides, like I want you to do it because this is your material. If not, I can take over, but I think it's best for people to listen to you because I think people get sick of me.
Yeah, sure. And then, yeah, if you have anything to add, feel free to interrupt or just.
Oh yeah, for sure. Yeah, I love the prep that you did for this. So thank you again and again for. It's very I like it. It makes me excited.
Yeah. So mechanism of injury. So obviously, depending for strains themselves, it's kind of that like one mechanism of injury versus like a tendinopathy of the hamstring. It'd be a gradual onset. So for strains themselves, yeah, it's usually like very commonly sprinting. So it's usually non-contact. So if you're like a football player, full sprint, goes to kick their leg out, and you get that little bit of a mismatch between the concentric contraction of the quad and then the eccentric contraction of the hamstring. And then usually, yeah, kicking is another one that's really common. And like I said, it's very common in football and track and field, I would say most commonly. I don't think I had any basketball girls this year with a hamstring injury. But yeah, it can happen in any sport or anything where there is sprinting. And then, yeah, usually right away, the athlete will report, or whoever has that hamstring injury, pain in the back of their leg. And then the bruising can take a few days, and depending on if it's kind of a tear in the muscle belly itself or in the tendon, can get a little bit more bruising or less bruising. So more bruising or less doesn't necessarily mean it's worse injury all the time. And if there is an injury to the tendon, so feeling it way higher up, closer to where the muscle originates in that ischial tuberosity, then typically that's a little bit of a longer recovery, which we can talk more about in a little bit. And then, as I mentioned at the beginning, yeah, about a third of hamstring injuries will reoccur, and usually within like the 2-week span of return to sport. But yeah, commonly if someone comes into the clinic and they have pain in the back of the leg, that's one of the first questions I would ask is they've had a previous hamstring strain, because they would be more susceptible to another one after that. Very predictive of re-injury. And yeah, like I talked about it before as well, it is one of those injuries that you want to make sure it's fully rehabbed before sending an athlete out to start sprinting again, just because of that high risk. Yeah, and some modifiable risk factors. So hamstring weakness for sure. The imbalance between the hamstring eccentric and quad concentric. So when your quad's shortening, so if you're going to knee extension and your hamstring has to control that movement, we're putting a lot of stress on the hamstring. So if you're going to kick, or if you're in that full sprint, then that's again commonly where you'd see those injuries, or you'd feel the pain, or just more susceptible. And then any like hip quad flexibility, stability, strength, tightness around your hamstrings, hip flexors, and quads as well. And then coordination deficits and pelvic trunk musculature, which I think is like most injuries, like kind of that whole or their whole chain of movement. So core, hip, hamstring, quad, all of it, kind of that holistic approach. So making sure addressing all those factors and figuring out exactly what caused the hamstring strain itself. So yeah, injury prevention. So one of the major ones is the importance of hamstring strengthening for preventing injury, including ACL. So theoretically, that's the ACL is preventing that anterior translation of the tibia, so that forward translation. Your hamstrings are kind of the agonist to that movement, so it's stopping your tibia from moving forward. And again, that imbalance between the quads and the hamstrings can sometimes just be more susceptible to an ACL injury. And then, yeah, again, injury prevention. So if an athlete or someone's going back too early and they still have a little bit of a strain, or their muscle's not quite ready to place that load that someone wants to do, then you can have that high rate of re-injury. So it's got to be that gradual loading, and depending on the extent of the original injury, the timeline can be different. And we talk about, I know you've talked about this in previous videos, but grade 1, 2, or 3 strains. So grade 1 strain, I think you talked about it as well, the rope analogy, which I really liked. You don't want to just be like there's a tear in the muscle, because that really freaks people out sometimes, but just that fray. And I find like to diagnose someone and say you have a grade 2 hamstring injury doesn't give a lot of information. There's such a wide variety of like, it could be like just like a little bit frayed in the muscle, or like almost completely frayed. Like there isn't really a good diagnosis to say, oh, this is grade 2, this means like 4 weeks. It's so variable in that. So I mean, sometimes like I will talk to people about that, but I don't always approach it of like, okay, you have grade 2, this is how long of a recovery, just because it's so variable in that diagnosis itself.
Yeah, like I don't use the word tear anymore.
Yeah.
Strain I like, and usually like it's no fault of anyone, is if you hear tear, you think it's just like just gone, right? So that's why I like the rope analogy, just fraying the fibers instead of like cutting them like this.
Yeah.
Yeah, so I think that's a good point that you mentioned, is the vocabulary that's used, and just make sure people understand what a strain really means. So I think that's really good that you covered that. And I'll go right back to the next slide here. Awesome.
Yeah, so yeah, some I'll probably add a few exercises too, but I think the most important one is that the early stages you're getting some sort of contraction of the muscle. So it's not like, and again, you've talked about this before, but you're not just on complete bed rest. You're not using your leg. Sometimes like people will use crutches for a day or two, just to stay off the leg, prevent like a ton more inflammation, but that doesn't mean you're not going to use that leg. So doing some isometrics, so you're just kind of contracting the muscle but not even moving it through that range, so you're just starting to get it going. And then range of motion exercises, so not necessarily against resistance, but just even lying on your stomach and bending your knee up and straightening it again, or standing and bending your knee up and straightening. And sometimes, yeah, depending, early to mid stages, I would get people on a bike fairly quickly to get the leg moving, depending on their tolerance. And sometimes people who have like a more proximal, so higher up to that ischial tuberosity, don't always like the bike, just because it can be painful to sit on it or even sitting for long periods. So it's always kind of taking that into consideration. But having some isometrics or just contracting the muscles, whether it be your leg straight and you're kind of just pushing down into something without moving the leg. It doesn't have to be full strength. You're just kind of gently pushing in that pain-free zone, so it shouldn't be painful. That's typically what I start out with, and then educating people on, especially when it's acute, so when it's in that first like 48 to 72 hours, not to be overstretching it or sticking a lacrosse ball in there or anything like that, because that can tend to make it a little bit worse. And again, if you're having those like little bit of frays and then you're trying to overstretch it, a lot of the time it just makes it worse.
Mm-hmm.
Yeah, and then I don't know if we want to show any of these exercises, or maybe show them at the end, or.
Yeah, we can show them at the end. I can. I have beds set up here too, so I can do quite a few things with you.
Okay.
And equipment. So if you want me to do anything that has equipment, I got like I got the RDLs, I got kettlebells and stuff like that. So
okay, perfect.
Whatever you like. I can do them right now if you want. If you want to talk through them while I do them, or.
Yeah, we can save them to the end.
Okay, let's do that. Yeah, let's get through this and then yeah.
Okay. Yeah, and then mid stage. So again, like I don't necessarily like putting like exact timelines for all of these. It kind of depends on the patient's symptoms, how things are going, what their strength's like, and again, the severity of their injury. But once they're kind of past that isometrics, they're able to do strong contractions, they're able to get their mobility back. Then yeah, do some hamstring flossing, just literally lying on your back. We'll probably show this one. And you're just straightening and bending your leg. It's kind of a warm up. Sometimes I'll throw in like a good morning exercise too, as a mobility warm up. And then a hamstring stretch. I like the contract, relax against the wall. I think that might be a good one to show.
Yeah.
And then just some glute bridges. So usually I'll start out with both feet are on the ground. You're doing glute bridges, making sure those are pain-free, and then progressing to single leg as tolerated, as well as doing some single leg RDLs. And then beginning some light running, return to running stuff. And I think we have a slide a little bit later on that talks about general return to running guidelines too, which we'll probably go over.
Boom. Right there.
Perfect. Yeah, and then late stages. So once all those are pain-free and you're able to like get the patient through all those, then yeah, like explosive movements, sprinting, plyometrics, and then the return to running. So this is one that I've generally used, and it beginning around like 50% of max speed, and then only going up by like 60 to 70 once if the athlete feels or patient feels no tension or pain. So yeah, it would depend. It's not like you would do back to back days of this. You kind of want to see how the body reacts, and especially if someone feels the soreness after doing it like 24 hours later or the next day it's really sore, then that's probably a sign done a little bit too much. And again, you want to be slow kind of getting back into the sprinting. But yeah, I'll usually just do like forwards, backwards, and then forward with transition to back pedal, and then back pedal with transition to forward, and then cutting, things like that. So you want to stress the muscle in as many different ways as possible so that it's getting that variable load and you're not just doing a straight linear movement, because again, that's not going to be functional when you transition into a sport or whatever you want to get back to. You're never just running forward. So making sure that you're addressing all of those. Yeah, and again, you just modify it into whatever the patient or athlete requires. So especially for like different football players, you wouldn't have the exact same running demands on the court. So you just want to make sure whatever intensity they're going to be doing on the field, whatever kind of movements they're doing, you're training that off the field and making sure they're ready before they go back in.
Yeah.
The other one is, which I don't know if it's on here, but if you Google the running clinic, they also have like a return to running program. Oh, this is perfect. Now you can just pull it up. It's a kind of nice like step-to-step guideline. So often I'll print this off for patients and give it to them just that they can follow this. And it's kind of nice to have, especially now if you're not able to. Yeah, exactly. So it breaks it down week by week. And again, like this is a little bit variable. I won't always start people on that very low end. Like they might start a little bit higher, or adjustments will be made depending on extent of the injury, who they are, kind of like all their own like personal factors as well. But it's just kind of nice because if anyone is returning to running after an injury, it's just a nice way to kind of get back into things and have that guideline, which is awesome.
And if anybody wants this link, just let me know, or one of us know, and we can send you the link. I shared it with Rob, our running physio. So, so yeah, this he's really excited about it, and he did some research in the past, so he seems to be familiar with the program. So I'm glad he might even try them out. Who knows? Rob loves that stuff. Yeah. So that's great. We can send that link to anybody and we can go through it for sure.
Okay. Yeah. And then this was just from an article, Erickson and a few different authors. It was from 2017, but it's just kind of a nice way to go through. You're looking at, tenderness to palpation. If they have it, you're kind of continuing at the current phase. And then you're doing strength testing. So I think I talk about this in the next slide, but not even only just doing like the gross strength test, but making sure you're looking at kind of the recruitment and how quickly someone's able to turn on the muscle fiber. So if there's a little bit of a delay or lag, then typically that would mean they're not quite ready to return, because you don't want that delayed response. And again, you're comparing it to the other side, but and the H test. So I've never actually really done this one, but it's just a straight leg raise you're having the patient do as quickly as they can. And if they feel any insecurity or apprehension, then you're adding another 1 or 2 weeks. And then single leg bridge test, greater or less than 30 reps is what they used in this. And then sport specific movement, or again, whatever the patient needs or whatever you're trying to return to, making sure you're gradually increasing that load. So you're not just going from 0 to 100, you're slowly loading it up and making sure, okay, checking in 24 hours later, do I still have a lot of soreness, or like hours after you do it, are you having a lot of pain? Because then likely it was overloaded and you kind of have to ease off. So it's a lot of listening to your own body, which some people it's easier, some people it's harder, but kind of using a little bit of like a pain scale. So I usually tell people if your pain is going up as you're doing the exercise, it's too much. If it's staying consistent, or if it's a little bit of discomfort, sometimes you have to push through it. But yeah, definitely if it goes from like a 4 to a 6, then you're really going to want to ease off. And then eventually getting back to sport, getting back to sprinting, things like that. And then
we got the additional topics if we want to.
Yeah, I think we can go through some exercises.
Yeah, let's do it. I can. Luckily, I wore the pants that are exercisable, I guess. Perfect. Professional and exercisable. If that's not a word, but yes, you tell me what to do and I'll do it. And
yeah, we could show just a few like the basic isometric ones. So I mean, typically I'll either do like have someone lying on their back and they're just in like a straight leg position, and then their legs up on like a chair or bench and they're just pushing down into it.
Yes, let me set that up for you.
Okay, perfect.
I have a stool with wheels on it. Probably not the best thing to use, but
It'll work.
I'm a physio, so I can do whatever I want. Sorry, no. Okay, so I got. Maybe I'll move this a little bit here. You won't see the whole entire picture of me, but you'll see my foot and what we're doing. All right, so you said to lay down.
Yeah.
You can cue me with 1 foot up.
Yeah, so your whatever injured leg would go up, and then I'd usually just start, like, obviously have your core engaged still with any exercise, and then you just gently push your heel down into whatever you're doing it. So you can do it at variable heights too, and yeah, you push down to the point where you feel like you're getting some tightening, so some contraction in that back of the leg, but not so much that you're getting a lot of pain. So especially in early stages, you wouldn't just push down as hard as you can. You can start at even like 30-40% of what you think your max strength is. Do it for about 5 to 8 seconds holding, and then relaxing, and doing that like 8 to 10 reps, repeating that 3 times, a couple times a day, just making sure that you're still getting some firing of the muscle. And then you can play around with it. Like I said, you can kind of get higher, lower surfaces, and then you can also do it at different ranges where your knee's a little bit bent. So again, we're kind of getting as much as we can without actually moving through that motion if it's too painful.
Yeah, I can feel a good pull right in the back of my back of my leg here. So
perfect.
Especially with my knee bent.
Yeah. And sometimes they won't even have their leg up when their knee's bent. They can even just do it on the ground, like kind of just pushing into it, but not doing that full glute bridge.
Yeah.
And then once they're able to get like a strong isometric contraction, the range is better, they're not super tender or painful back there, then I start progressing into those like bilateral glute bridges. Yeah, let's do it. Yeah, so bilateral, yeah, just both legs down, core engaged, and just pushing up. Sometimes the tendency will be to compensate, so you might feel like your weight is on your uninjured leg, and so you have to be really cognizant of making sure you have equal weight between your heels, and making sure you're not shifting over. And then for glute bridges, sometimes I find if people's knees or their heels are too close to their butt, they'll feel it quite a bit more on their quad, and if they slide their heels out a little bit more, you feel a little bit more in your hamstrings. So those are a little bit different adjustments just to make sure you're getting that contraction in the hamstrings. That looks great. Yeah. And then from there, the progression eventually would go to like a single leg, which can be a little bit more challenging for sure. Yeah. And then pushing up. Looks great. Well, 10 out of 10.
I'm trying as hard as I possibly can. No, just kidding.
And then maybe while you're sitting down, the hamstring flossing. Have you ever done it or used it?
I actually haven't done hamstring floss. Like I do like the flossing for nerves, like the tensioners, but not specifically a hamstring floss.
Yeah, I don't know if flossing's the right word, but that's what we call it. But you just lie on your back and your hips at about, I mean, it could be between 70 and 90 degrees flexion. It's just like kind of a good warm-up one. Yeah, and then you can hold the back of your thigh, so kind of like where your hamstring is. And then you would just, from here, just straighten and bend your leg. And you don't have to straighten it all the way so it's perfectly straight, but just so you feel a little bit of a stretch. So it's kind of like a mobility stretching exercise. But it's kind of a nice warm-up one too, where you can adjust it. And then if you're like, that's way too intense, then you can always lower your hip down a little bit more and then just go from there. So you're feeling a stretch and you're kind of going from a stretch position, not stretch, stretch, not stretch. It's kind of a nice one to mix in.
Wow, yeah, I like that quite a bit.
Yeah, it usually feels good, and I find like again, sometimes it's more effective to do kind of those more dynamic movements than just that like kind of static passive stretch, especially before you're gonna go work out or do anything like that.
Yeah, no, that's a good one. I like that.
Yeah, and then the other one would be, which I don't know if you have a wall. I have a wall beside me. I can maybe show it, but the contract relax in that kind of like against the wall where you're pushing into it and then coming off, pushing into it.
Yeah, I can set that up. I have a wall.
Yeah, Michaela just said she's done it. That when you're lying on your stomach, you have a heat pack on your hamstring, and then doing some mobility exercise too.
Actually, you know what? Let me maybe lower this down a little bit more. This tripod is so great. Actually, there we go. That should be good. So the wall's here. My legs against it. This is the starting position.
So usually like I would have you lie on your back and then your leg is up against the wall. Does that make sense?
Oh, okay. Yes. Sorry. I thought I was doing the extension. So okay, I can do that.
You can do that too as an isometric.
I can. So legs up on the wall. Okay.
Just one leg. So the other would be like kind of straight along the wall, and then the other one's kind of in like a 90-degree position against the wall. Does that make sense?
Okay, yeah. I can do it. This is a doorway, so I could just have.
Yeah, so you'd be stretching the one leg up against the wall.
There we go. Okay. All right. We're good.
Perfect. Yeah, so this one I like too because it's kind of like a self contract relax. So you just go to the point where again you feel that discomfort. You don't want it to be super painful. A stretch should never be so painful. A little bit of discomfort is fine. And then you hold that for about 20 seconds, and then you can push your heel down into the wall. Again, this wouldn't be early stages, kind of mid to late stages, but you push it down for about 5 seconds, and then you're going to relax and then pull your foot a little bit off the wall and then slide your butt further down. So you end up in whatever range you pull your leg off. That's the new position you're going to start at. So I know like physio school, we learn muscle energy technique and things like that. This is just one that you could do at home to get that. You kind of push, and then you have this like little bit of time where you get the muscle can go a little bit further, and so you're just working on that range. So that's typically what I like doing versus just like a static passive stretch.
Yeah, that's a good one. That one I've done a few times, and definitely a really good stretch for me.
Yeah, I have to do those later. Yeah, we could show, well, you could show, I'm not doing any exercise right now, but
That's
the
okay.
single leg RDL.
Yeah.
So I think that's a really good go-to one. Works on kind of, again, we talked about earlier, that trunk and pelvis core control. So it works on a little bit of that balance, and then you're working on that whole posterior chain, which is awesome. Like, I'm just gonna test your balance here.
Should I grab a kettlebell or?
Yeah, you could. I sometimes find it easier when I have a weight in my hand, but
yeah, I do too. It's kind of weird not having. I was just like, this is so weird. And sometimes I get patients to use like a couple of books or like a stool here. That way they're just touching down to that if they can't.
Yeah.
So.
Oh, yeah, great. Yeah, so I think that the key for this exercise is not to like exactly what you're doing is perfect, because you don't want to go like a lot of people tend to almost go into like a single leg squat. So you don't want your knee completely locked out, but just exactly what Sunny's doing, just a little bit of a bend in the knee. And then just a very slow, controlled movement. And again, the weight is optional, but it's sometimes a little bit nicer to have that balance. And you're just kicking that back leg out. And having that weight really close to you, so you don't want it way out in front of you. Just nice and close, or your arms nice and close. Yeah, and then feeling the work in your glutes and in your hamstring as well.
That's a good one. I threw the weight away just to show people what it looked like without a weight, and it looks like I don't have a weight in my hands.
Perfect.
Oh, I got a question here.
Oh.
What are you guys' thoughts on hamstring curls for rehab? Are they functional? Do they have a place?
So I think, and I sent you this article, but so the Nordic hamstring curl, it's like a 51% injury prevention rate. So I would say, I think, yeah, all the athletes at UBC strength and conditioning had some component of hamstring or like Nordic curl.
Yeah.
So that would be like kind of my go-to. Some patients I might still do like some banded curls as well, just depending on their equipment at home or kind of the severity. So you're getting some resistance. I don't always find that it's the most like functional exercise, but I would probably pick a few others, and then for sure doing some Nordic curls depending on the patient.
Yeah, I agree with that. I start with it sometimes just to test it out. I probably use it as like a screening tool more than anything, and then getting into more weight bearing activity. So
yeah.
That's
Can you demonstrate the Nordic curl? Do you have somewhere you could do it? If anyone doesn't know what we're talking about, if someone to hold your legs as you.
I could try to do it with my rig here. I won't be good at it, that's for sure.
I'm not. That's what I'm like. I can't demonstrate. No one's here to hold my legs.
I can't because I'm probably not strong enough. But I'm gonna fall on my face. That's every time I do it.
Yet again, I wouldn't say like this is necessarily important for everyone, but like for football players or like those certain athletes, it's definitely a good one to mix into a strength and conditioning program just because of the evidence of it having injury prevention.
You see a lot of it nowadays, for sure.
Yeah.
Okay.
For people who can go like all the way down, just hover and then come back up.
Or go partial, right? You can go partial as well.
Yeah.
I don't know. Oops.
Uh-oh.
That's just a clip. It's not a big deal. I don't know if my feet are going to stay, but the point is just to...
Yeah. Go down and then, put your arms out. And then, like, I even, like, sometimes I'll have people come down into, like, a push-up and then, like, kind of push back up. But then just that slow lowering down is kind of the key.
That eccentric. So going into, like, a push-up then?
Yeah, and then you just put your hands out and then kind of push back up into your starting position. Yeah.
Okay.
And then,
one for me.
yeah, and then like some people will have like someone holding their ankles.
Yeah.
Or if you had somewhere where you could do it, but it's not always the easiest one to set up.
I'm exerting a lot of plantar flexion so that my feet would stay in that rig.
It's fair.
All right.
That was good. That was great.
That was a good warm up. I got to lift tonight, so
perfect.
Somehow I'm gonna try, but yeah, those are good. I like it. I like those ones because then you got like that muscle control, like the neuromuscular control. I know a colleague of mine, Yehia, talked about neuroplasticity and things like that, and doing things to a metronome beat, and that's quite interesting. I think I'm going to try a lot of the stuff that we've talked about with metronome and see improvements for me, because I do have some hamstring issues. Not like a strain, but it just, they get very, very tight with especially the heavy squats and things like that. Yeah. I love glute bridge with a curl on a ball too. Yes, that's a good one. Good for balance and core, for sure. That's a good one as well.
Yeah, that one I typically do. Yeah, more towards like late mid stage to end stage, because it's a very challenging exercise, especially when you go into like a single leg glute bridge on a ball. That can be challenging, or sometimes if you don't have a ball at home, going into the glute bridge, but if you have a hardwood floor, putting towels under your feet and then doing a slider with that as well.
That's a good idea.
Yeah, so you can go up into the glute bridge, have some towels like underneath your heels, and if you're on like a soft surface or have socks on like a hardwood floor or tile, you can just slowly extend your just straightening, and you're getting that eccentric control, and it's the hamstrings for sure. Yeah,
that's a very important thing to do. Like, I like with the research, like some of the articles that I know we discussed and went back and forth with, like a lot of it consistently shows eccentric training is going to be beneficial. There was one article that even had like stretching as well, and stretching for a lot of areas is just a big question mark. But that showed some evidence, and then even like the interesting point of fatigue, like we all know fatigue is an issue, an injury, and there's one study that linked that together with hamstring strains and also ACL injuries as well. So very interesting when you look at the research behind it.
Yeah.
I find it's one that like a lot of people, everyone's had like some sort of like pulled hamstring before. So most people have. Have you?
I think at some point I've had
Yeah.
like a hamstring. I don't think it was maybe it could have probably been like a grade one. Nothing like where I was out for a long time, but
Yeah.
I think it's so common. Like obviously, majority people your quads are going to be stronger. There's nothing wrong with that. But when you get into like a more significant imbalance where you're very quad dominant, like want to make sure you're balancing out glutes, hamstrings, kind of addressing all that.
Yeah. I think that balance thing is very important. Like you hit the nail on the head there for engaging everything. I think a lot of the times people might be, and it could be physios included, might just be engaged in one area alone. So looking at the hamstring and that's it. Your eyes are like fixated on that one muscle. And I think that core and low back gets missed and how important those things are. That's why, like you mentioned, the single leg, like we did, well, we did the single leg RDLs. I like those because again, you have the core, you have the low back, you have the hamstring, glutes, like fire. And same with the good mornings even. I like those quite a bit. Uh-oh. Laura has frozen, but I will continue. So we might just have to reconnect with her. Oops.
Yeah.
I think
Oh no,
Laura
am I
is just.
frozen?
There we go. Okay, we're good now. It's a bit delayed, like your lips are delayed to the audio. Um, the videos. Uh-oh. She left. I'll have to invite her again. So I was just gonna say, let's see here. Let me just add 5-minute physio again. Done. Okay. So I was gonna say I like good mornings too because that gets your back core. And oh, there we go. I think it just.
Sorry,
Oh no, it's just.
technical.
It happens. It happens. Instagram's getting a lot more volume these days. But I was just saying, like good mornings, I like doing a lot because um, I like the stability of the core, the back, glutes, hamstrings. You kind of feel it where you need to feel it. Like some people, like it's cool exercise. Everyone feels a little bit different. Um, yeah, and I like that controlled, like eccentric control is important. So yeah, those exercises are awesome. I feel it. I feel it gentle.
Yeah. Yeah, definitely like yeah, some sort of dynamic warm up is key. And I think it was yesterday, was it 2 days ago you were talking about like just in, like even when you're going to squat, like importance of warm up, getting on a bike, like yeah, like some people maybe want to put a heat pack on before doing exercises, but either do like a combination, do
Yeah.
heat pack and then some sort of active dynamic warm up, or trade it in for active warm up in general, which I'm like key for. So biking
Yeah.
and getting some activation, glute activation, hamstring activation, kind of priming those muscles before you're going into stuff where if you're not warmed up, then you might just be a little bit more susceptible to injuring something.
Yeah, exactly. Yeah, that's definitely great points. That the warm up is so important. Like, I mean, I always go examples of what I see and what I do. And again, if you're going to go into a squat program or sprint and you don't warm up, like you're going to feel, you're going to notice improvements over time. And that's just because you're warming up. There was a comment here. It's definitely one of the biggest complaints I hear following ACL surgery, especially with a hamstring graft. Yeah. Yeah, I get quite a few people that have issues back there. What about your experiences, Laura, with ACL rehab or post-surgical rehab?
Yeah, quite a few. I had two ACL girls. They both got a hamstring graft, and then more recently there was a few football guys who tore their ACL, but they didn't have hamstring grafts. Like I think there's like I could be wrong, but some surgeons are moving away from it just because I think like it's just harder to get that strength back
Yeah.
and and things like that. But yeah, definite major complaint.
Mm-hmm. Yeah, and then again, like you said, it plays the part with the ACL, so important to strengthen that area. I find a lot of like there's a lot of quad control, which is important, but a lot of quad push for ACL rehab, but hamstring might not get worked out as much, so to speak. But um, yeah, like definitely a very important muscle. Like everyone saw how large and powerful those muscles are, and um, in any kind of explosive sport, they're going to play a huge part. Um,
Yeah.
yeah, that's why I like squats so much and those kind of powerful motions is because you get the eccentric concentric control of things. And like the RDLs and the good mornings, like you got multiple segments. Obviously, those are going to be not early stage rehab, but it's nice when you get functional and you get more activity done and focus on more muscle groups. So I think those are great points. Keep the questions coming, guys. Those are good questions.
Yeah. And again, I think the key is like sometimes like I've had people or patients and athletes be like, my hamstring feels great, like it doesn't feel painful, and then try to go from that stage where, okay, it doesn't feel painful, but you're going to go straight into a sprint, and you haven't had that in between where you have to still gradually load it up. And I think people get too excited because they're like, oh, it feels so good, and like I feel like my strength is back, but then they're compensating and then they go back too soon.
Yeah.
Or if they go back and they're just scared of re-injury, that's sometimes like that psychological component as well.
Yeah.
So kind of making sure you're addressing everything before you're sending someone back out onto the field or into a sport or whatever they're trying to do.
Yeah. No, that's a good point. Any big changes you make to exercise for proximal versus distal hamstring rehab from an exercise standpoint?
For me, I wouldn't say major differences in the exercises themselves, but more proximal. I would say I'm predicting a longer timeline for return to sport, and especially if I think the tendon's involved, then a little bit longer. And then I would say for the most part, it would be similar exercises. No matter what, I would still have some component of concentric, eccentric, like isometric, kind of addressing everything. So you're loading it as many different ways, and then. Yeah, I wouldn't say like for me, I don't know about you, but I wouldn't say there's major differences, but more just like timeline and depending on how the patient's doing.
Yeah, I agree. I wouldn't not necessarily the program change, just the like exactly what you said is the timeline. If it's tendinous, then it's going to be a little bit longer versus belly. Yeah, so how to progress? I would just do a little bit slower if it's more of a significant tendon injury, if it's at the tendon versus the belly.
Yeah.
Yeah. Lots of
I know, yeah, maybe a little bit eccentric, a little bit more eccentric focus, but
yeah.
I mean, either way, I would still have like quite a bit of eccentric in both situations.
Yeah. And Michaela is, you said the other part of the 5-minute physio?
Yeah.
Okay.
Yeah, it was her idea. I hopped onto it.
Second half? Equal parts of 5 minutes, 2.5 minutes each?
Yeah, maybe something like that. Michaela's way more tech savvy than I am.
Oh, yeah. It sounds like I need her around. And then we got Brooke. Any manual therapy techniques you use as a physio throughout the recovery process? Great question.
I just dig my elbow. No, I'm just kidding. Yeah, I think again it depends on like you're looking at everything, right? So I mean, if depending on what you're seeing, if they have hip flexor tightness, I'll usually do some manual release before I have a patient do exercises. Sometimes I'll do like a little bit of met stretching with them just to loosen stuff up. But I would never, yeah, again, just do manual therapy without exercises. So it's always before, and sometimes, yeah, like a little bit of massage or release techniques. Sometimes I'll do active release back there. Not everyone likes it. Yeah, I don't do needling, but I've seen people do needling as well.
I've done IMS for this, very effective. If it's with exercise, like you said, always. And IMS being not manual therapy, that's just an adjunctive treatment. So
yeah,
IMS is beneficial in some cases, but not always needed. It expedites the process for sure. Like it just makes things a bit more comfortable, a little bit faster, with some cost associated with it. It was discomfort while it gets done. And I know there was that research article that I looked at that showed some benefit of deep transverse frictioning to the ham, like essentially wherever someone's sore. So at home, for instance, taking a ball and rolling in small little motions along the tendon or along the muscle. There was some benefit of that. Yeah.
Yeah, sometimes at home too, yeah, with the ball, if someone's sitting in a chair and they just kind of gently place it under and then do like their they're straightening and bending their knee. So you get a little bit of that active release with the ball kind of underneath as well. I like that one, but
yeah, I like that for sure. Yeah, lots of people, again, like now it's always all about education and self-management and exercise. So manual therapy is a great technique, but I think a lot of this can be managed on your own, right? So getting the education from physio, progressing as they recommend it, and doing those techniques when needed. So
yeah, loading it. That's the key. Yeah. Those hamstrings.
I'm a lot different in the way I treat now than I did maybe a few years ago. Nothing wrong with that style, but now it's even more so putting the ball in patient's corner or court and saying, hey, like, here's what you do, and like, just show me that you can do it. And then they kind of get hooked from there. And then you see patients less pain being the most important thing. Yeah, and here's another one. I love what you guys said about checking the surrounding muscle too. No tunnel vision. Yes, I always, who was it? Who was it that told me? I think it was Judy, the great Judy Shapea, who told me, and it always stuck. There's a few things in school that like were like the eureka moments, and one of them was check above and below each joint, or distal and proximal to each joint, and see everything else, right? Like, how does the knee affect the back, the hip, that kind of stuff. So yeah, no tunnel vision indeed. And also patient response-based feedback from Jeff Boschtik. That was a huge thing. I use that so much, like, just, you know, and that's actually a good point. Do these stretches, do your activity, and you can measure change right away. Like, either you're going to do your, like, let's say if you're doing the wall stretch, you'll know roughly how many degrees you've improved. You can just take pictures and stuff like that. And then also using like your sprint or whatever your return to sport is, using those guides as okay, I've stretched it, okay, now running's easier, or I rolled it, it's easier, or I did a cueing or activation exercise and I'm jumping and it's not painful. So yeah. Anything to add on that, Laura?
No, yeah, I completely agree.
Yeah, that's cool. And you're like, for you said you can challenge the exam. Like, how does the exam work?
So there's a written component that happens in September, and then there's a practical component. Usually happens in April, which I don't think it happened this year. But so you have to do the written component first, and then you do the practical component, and then you need so many hours with contact, non-contact sports on the field.
Yeah.
In order to apply for it. So I mean, they set it up at UBC so that you get those hours. Like, even though I didn't finish, because obviously the pandemic, I still have enough hours where I can challenge the exam.
Yeah. Cool.
Which is exciting.
That's pretty good. That's really cool. Yeah. It's good because I don't know too much about the program, so maybe I'll join you.
Yeah. I mean, well, it's not happening right now, but.
Oh yeah, one day. Actually, no, I can't leave this place. I gotta.
You have a clinic.
I'll work with some teams here. Vinny Rehab, one of my great mentors, my master, regional interdependence, I believe. I haven't heard that term. I assume that's one region is dependent on the other for like, if you're looking at the knee and the back and the hip, those are all interdependent. So I assume that's what that means. Hopefully I'm right. You can correct me if I'm wrong, Laura.
That sounds right.
Sounds right. Okay, that's all. Hopefully that's. Well, it should be something else.
Just say it confident enough. And it sounds right.
Well, it should be like fashion advice. Your blazer must match your pants. Michaela said the best part of virtual therapy is actually using the photo tool in real time. So taking screenshots pre and post and sharing with the patient. Yes, that's actually. That's amazing. See, tech savvy is right there. So that's a great point. Like, I usually get patients by a wall, or like if I'm doing tele-rehab and they're always in the same room, I'll just tell them to stand by something like a visual like cue for me, and then I'll know if their range of motion is improved. But yeah, it's actually, tele-rehab's pretty cool because I can just move the laptop or whatever device I'm using and kind of just set it up. Like today, for example, I had the tripod with the phone, and then I had the laptop on a stool and just sliding around all over the place. So much tech,
You're working.
so tech savvy. Haha. Yes, for sure.
I don't know how to take, but no, I'm just kidding. I could probably figure that out. But
Because Michaela's in Calgary, right? Or no?
yeah, Michaela, so she's at Lifemark Village Square in Calgary. So I think, yeah, they're taking in-person patients too now.
Yeah, so
And so.
everyone go visit there as well. Unless Michaela wanted to move to Edmonton, and then we can also learn some tech skills from her.
I think she said she wanted to move to Vancouver. Really cheap to live here, so she was really keen on it.
Yeah, I can't. Yeah, Vancouver's just. It used to be home for me. I talk about it to this day. Oh, Dan Schultz. Dan, one of the owners of he's an Olympic weightlifting coach that owns Farmstrong Athletics. So, hello, Dan. Huge things you got to see. I want to post this on YouTube. So, for everyone, this will be posted on YouTube and you can watch it, take your time and pause and try some of the exercises. So, Danny, very good to see this for the athletes. That I train at Farmstrong as well, so I'm a huge supporter and advocate of Olympic weightlifting. I wish there was like a logo I could show right here.
Sponsored.
Yeah, this is just like with the banner, just like that. You guys can fly me between those two. Okay, that's fine. I'll take you. Maybe we'll do like a 7-and-7 shift, 7 days on, 7 days on in both cities with no off. That sounds
that works for me.
Your time off is just flying an airplane, so
that's perfect.
Yeah, so this is a great talk. Like I know there was additional topics which maybe we can do another day one day and talk about that. And yeah, I'm really happy with the content. And again, your expertise in this field is amazing, being sports specific and things like that. And I truly value your time and your experience for today.
Yeah, this was great.
Yeah, and we still got like another minute, so if there's any questions, but I just wanted to say thank you before sometimes it gives me the countdown, sometimes it doesn't. So I feel really bad when it just cuts out and I'm like, it's not me.
Is it limited an hour to go on Instagram?
It is an hour, yeah. So
interesting.
I don't need time off. Do it again. So helpful. How about Michaela? You come on with us as well. We'll just take turns and
rotate.
Yeah, I can't do 3 people, but we can rotate. I think that would be a good idea. Reach out to me, direct message me or DM or whatever it's called.
Yeah.
Sound old. Brooke says, thanks, Laura. Great.
Anytime.
I think it's amazing with what you're doing and like making it so efficient to understand. And I think it's good for everyone. We got physios, we got Olympic lifting coaches, we got athletes, we got weekend warriors. Everyone who's attending is a mix of everyone. So I think it's difficult to kind of present in a way that everyone can understand. So I'm glad everyone finds it very helpful. So thank you, Laura. Any closing remarks for you?
No, yeah, thanks for having me. It was fun.
No worries. Yeah, for sure. We'll hopefully see you soon. And let me know if you want to do like a part 2 or have another another part or another area. I think this is good to connect.
Yeah, it sounds good.
For sure. You have a great day. Enjoy Vancouver. Say hi
too.
Say hi to Vancouver for me.
Yeah, I will. I should have had Moose come on, but I don't know where he went.
As far as laying down, just hanging out, right?
Yeah. Typical.
Moose is her incredibly cute doggo. So if you follow her on Instagram, you'll see some cute pictures.
Just only pictures of him. So
yeah, check out 5 Minute Physio, guys. Follow them. And Michaela, you should move to Vancouver and Edmonton. It's great having you on the questions, and we should do this together as well. So yes, checking out. Peace out from Edmonton. Thank you so much.
Okay. Bye. Thank you.